describe here, although I do work with several companies on device development. The opioid epidemic is real in the United States, and I think if you pay attention, you see it everywhere. And although the economists say that we're inefficient in our healthcare, as Professor Lobdell pointed out, you can't calculate the cost of a life. And I think this image is really impressive, especially when you see there's little kids sitting in the back seat. Something we all need to pay attention to. And in Ohio, we've changed laws to limit prescriptions to 7 days. And we see that it's projected that more and more people are dying every year from this opioid epidemic in the United States. 64,000 people in 2016, which is more than car crash deaths or the peak of HIV and gun deaths at each of those peaks. But I think that this slide is also very important for us to pay attention to. And, there's a lot of different reasons why there's an opioid epidemic. But one thing that we can make a difference about is our role. And this evidence here suggests that the likeliness of a patient becoming dependent on opiates peaks and spikes, and the slope goes up just after 5 days. So it is really important for us to minimize the use of opioids in our perioperative patients. There's no question that it opens the door for some patients who might later find cheap heroin on the street. And we're paying attention to all the things that we do. So we have to deliver value. We have to deliver good outcomes. We have to pay attention to bundles and episodes of care. And this patient experience and bundles are things that we're focusing now more than ever. You can see that just over a decade ago, we only had 10 quality metrics. Now there's at least 92 of them. That star rating system that Dr. Lobdell paid attention to is just one thing that we keep track of on a weekly and monthly basis in our institution. But we also have to pay attention to all of these ERAS things that we can do for patients. And certainly pain is one of the most important ones that's related to what we do as surgeons. Pain is what the patient describes it as being. It is a subjective thing. So it is, amongst all those quality metrics we have to pay attention to, it's one that's a bit difficult to measure. In this study of nearly 1,500 surgical patients, the conclusion was that postoperative pain management was unsatisfactory. It leads to tachypnea, hypertension, sympathetic stimulation, which is also associated with increased complications in the perioperative period and worse outcomes. So it behooves us to treat pain better in many aspects. In this analysis from JAMA Surgery just in this last year, they looked at over 18,000 patients undergoing 21,000 operations, and they found that although 36% of patients received no opioids for that 24-hour period prior to discharge, 45% of that subset of patients received opioid prescriptions to take home with them. So we're likely overprescribing these drugs to patients. So what can we do about it? We can pay attention in all the different phases of care, certainly intraoperatively in the ICU, intubated and extubated, step-down units, and at home. What we do intraoperatively in our institution is work on better ways of delivering regional anesthetics and local anesthetics, including local blocks, long-lasting blocks, and cryo analgesic methods. For example, our patients undergo a mini thoracotomy operation for minimally invasive aortic valve replacement. Our anesthesia team takes that extra time in the morning to deliver their regional block, the subfascial block in the chest wall. And you can see in that image on the bottom right is an ultrasonic guidance of the needle into that very focal space with a long-acting agent, which provides pain relief for at least 24 and a lot of times 48 hours or more. Gets the patients through that early acute phase when they're transitioning from their intravenous opioids to getting up out of bed and getting moving. We also provide cryo analgesia to some of our patients. It's certainly proven to be most important in my practice, where I make some pretty big incisions, such as when we fix a thoracoabdominal aneurysm in somebody. And the idea here is by cryoablating the intercostal nerves for about a 2-minute period of time to a temperature of between -50 and -70 degrees, you destroy the axon. It's enough to only destroy the axon, however. We, of course, pay attention to make sure that we're not near the ganglion, so we don't kill a nerve cell. But there's evidence to suggest that only the axon dies and the neural sheath lives. That allows that axon to regenerate over a period of about 6 weeks or so, just enough time for them to recover from any issues, especially after a big operation like this. These are some of the most painful incisions. And empirically, we're working on gathering evidence, but empirically, it's remarkable how much better these patients do when we cryoablate 5 levels of intercostal nerves after a huge thoracoabdominal incision. In the CVICU intubated period of time, we work hard on minimizing the amount of opioids, and we use IV acetaminophen and NSAIDs with multi-modal therapy for these patients, and lidocaine patches along the incision as well. We get these patients extubated as early as possible. We shoot for less than 4 hours postoperatively. And again, we deliver these multimodal analgesics, and the whole team has access to increase the additional methods of analgesia control. We work on getting the patients up early. They're often in a chair early in the morning when we're rounding on post-op day 1. We also have healing services available. Anything that a patient needs, we push to try and get them to help with managing their pain. Once we get them to the step-down unit, we get them transferred over to oral medications as soon as possible. Our nurses are the pain champions. They're the ones at the front line, making sure that these patients get their pain medicines early and help them with requesting these other multimodal options. And when we get them home, they get a 1-week supply of narcotics. That's all we're allowed to do legally. And we provide continued feedback to these patients. We're working on developing electronic applications for this, where the patients can interact with our postoperative team. We have a nurse and pain staff on call 24/7 for these patients. That website interaction is something that we're launching as we speak. The multimodal analgesic options include many of the things on this list. We'll see if cannabinoids at the bottom of this list become something we add to our armamentarium as that becomes legal in the state of Ohio. But we certainly use the things at the top of the list. Not so much ketamine currently, but we certainly use all the other agents on the list. IV acetaminophen is important because it reaches high plasma concentrations early, and it's maintained. And most importantly, it reaches concentrations in the CSF that aren't reached with oral doses really ever to that peak. There's data that suggests that it reduces the length of stay, and for that reason, the cost of the drug is well balanced by that improvement in outcomes. There's evidence that gabapentin may reduce the need for opioids. We saw from our first speaker that they give their patients preoperative 600 milligrams daily. We're piloting a program for that in our institution now. Our goal should be to provide patients comfort, a pain-free or certainly as tolerable as possible recovery with early mobilization, which will lead to improved quality of life. And we think and we hope that we can gather more information to demonstrate that this improves patient satisfaction scores, reduce costs, and the efficiency and quality of care that we deliver. Thank you very much.